Welcome to the Ortho Joke Podcast, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. Join hosts Mohit Bhandari and Marc Swankowski as they discuss current topics and publications in the world of orthopedics and beyond.
Morning, Marc. How are you? I've got my cup of good old-fashioned Canadian brew. I hope you have a little bit for yourself.
I do.
And oh, you do. Very good.
Yeah,
We're going to have some branded. We'll have some branded cups for our guests, but you and I are old souls at this, so we can just grab any coffee we have.
Ramo, I just have to share with you that literally across the street from me, a new coffee shop is open, and it's Dunkin' Donuts. It's not Tim Hortons, to my disappointment. So, but we'll survive.
Wouldn't Dunkin' Donuts be the Tim Hortons kind of the U.S.? Am I wrong on that, or
not in these parts? But as you know, traveling to Boston quite a bit for the journal,
sure is.
It's the culture.
It is.
I once made the mistake of giving gift cards to the staff of Starbucks, and it was not well received.
Well done. Well, listen, today we are going to be chatting about a topic I think that is gaining more and more interest in the orthopedic community, but certainly in surgery, it's been around for a bit, which is weight loss, and specifically weight loss in obese patients as it relates to surgical outcomes. And you can't really talk about that without talking about the GLP-1 agonists. And I'm sure you and I could opine on this, Marc, but probably a good idea to get some experts. And the experts we've identified come from a partnered specialty area of general surgery. And I've got an internal medicine. So we have Karim Ramji, who is a general surgeon, bariatric surgeon, entrepreneur, a researcher at McMaster University, along with his colleague, Jamie Lee, who is an internal medicine specialist and obesity specialist, both working and helping bariatric patients in many ways have improved the quality of life and better outcomes. Welcome, gentlemen.
Thank you so much.
Thank you for having us.
Listen, I'll leave it open to either of you, but maybe I'll start with you, Jamie. Can you just give a précis on GLP-1 agonists? What are they? How do they work? And ultimately, maybe we can jump to you, Karim, about sort of their general applications in bariatric surgery.
Yeah. To understand GLP-1s are glucagon-like protein agonists, and so basically we have these molecules endogenous in us, right? So it's released by the gut. But you got to go back about probably 18 to 20 years now when GLP-1 first came out, right? GLP-1 was actually used to treat diabetes. So if you know Victoza, that's kind of the very first ones. And when they studied it, they see, wow, this is a huge side effect of weight loss, right? And over time, they developed better formulations of this. And obviously, there's been this Ozempic boom, right? And so it's everywhere on social media, TikTok. And one of the scary things about that is the way it's used, right? So there is the commercial side of it, and there's the medical side of it too as well. But basically, GLP-1s are proteins that are secreted by our small gut predominantly. And we have these receptors all over our body, in the heart, in the brain, in the pancreas, in your kidneys, in your endovascular system. And so the use of actually GLP-1s goes beyond weight loss, right? And so we're looking into patients with heart failure, with preserved ejection fraction. We know that it helps protect kidneys. We know that protects actually cardiovascular events as well. And they actually are studying it in actually the psychiatric world. And this is where one of the key things about GLP-1s. And so when I talk about GLP-1s in my clinic, there's a few things I always tell them. Well, what does it do, first of all, right? So the biggest thing that it does is that it basically reduces appetite, hunger, and craving, right? And that's one of the key things. And one of the mechanisms for that is basically slowing the gastric emptying of food into a small intestine. So when you slow that down, that kind of satiety sensation lasts longer. And that's how actually one of the true mechanisms of the agonist in terms of reducing blood sugar too as well, right? So very effective in blood sugar control too as well. Now, one of the important things is that it actually works in the central nervous system. And that's where our control center for our weight is, right? So, in the hypothalamus, we have hormones there that gets that controls our appetite, hunger, and craving. And that's the key. And this is where weight management has shifted dramatically. And so I'm not sure if you're aware Weight Watchers, Jenny Craig, all the stores, brick and mortar stores, actually have closed down. They can't compete with the efficacy of these medications, right? And because they're so effective in terms of weight reduction, true weight reduction, in terms of like central nervous system, reducing appetite, hunger, and craving, to the point where some of these studies, the first GLP-1 studies were about 10 to 11%, and we get the Ozempic, we're losing about 15% of your body weight, which is very, very phenomenal. And we get newer generations ones, the dual agonists that are able to lose up actually 21%. And I think down the road in the next 3 years, you'll see, reaching bariatric level of weight loss. And so, but the key thing is that even you lose the weight, the maintenance of weight loss is actually very, very important. And we see this yo-yo dieting. That's the problem with these short-term fix with Jenny Craig's and Weight Watchers. And they've unfortunately harmed a lot of kind of the management of weight loss, right? So previously, weight management was more commercialized. Now it's more medicalized. And so we're seeing a lot more specialty clinics, both medical and surgical, combining for the maintenance of weight loss. So there's still room for all of that. So that's kind of how I use the medication. And so we use it as a behavioral change tool, using various doses to mitigate side effects by looking at the maintenance of weight loss too as well.
On the surgical side, Karim, how are you using it practically now? So let's say you've got patients obviously considering bariatric surgery. So bariatric surgery itself, you would presume, would be the fix. How are you using GLP-1 agonists?
So it is a mainstay of therapy today. Basically has become a pillar alongside surgery in many respects. I think what Jamie's getting at is that there's been a seismic change in how obesity has been treated since the emergence of GLP receptor agonists. I think our mindset has also changed. There's a bariatrician, Sean Wharton, in Canada that's well known, and Jamie knows him well. And I remember at a conference he had said that it stuck with me that, obesity is not caused by overeating. It's rather overeating is caused by obesity, meaning that we've really understood now that there's a clear neurochemical genetic profile in individual patients that's setting them up for obesity. And because of that, we've started to understand, we've gone from, in the medication world, we've gone from, I would say the first generation of drugs, which are kind of like orlistat, which were, anti-absorption of fats. And then we went into limbic system type of medications like phentermine, which would affect your addictive centers. And then we realized that there's a balance center, the orexigenic system in the brain. What we found out with GLPs is that serendipitously, we didn't know until in the last maybe 10 years that the operations have done a very similar response from a biochemical standpoint, serendipitously. We call this, the hind gut theory or the distal gut theory, whereby undergoing either a sleeve gastrectomy, a gastric bypass, a SADE, or, a duodenal switch, that we were stimulating the distal gut to release from L cells to release GLP, which would mimic this same impact or that the drugs are mimicking, that would increase these basal levels in the body for patients and extend that postprandial satiety that patients experience. But then on a biochemical level, it would improve their insulin and glucagon profile and have multiple impacts, on quality of life and quantity of life. So from a surgical standpoint, we're finding the majority of patients come to us now prior to surgery have already been on GLP agonists today. And either they've plateaued, and maybe Jamie can speak about some of these patients, but they've plateaued in their success. They've, frustrated that the costs are still exceedingly high, or that they've become tired of using these drugs in the long term. If you look at the long step trials that have been done, most of these patients were on these drugs for 5 to 6 years. But the real world study shows that most patients are on these drugs for about 8 to 9 months. And there's a drop-off rate of almost a third of patients in the first 1 to 2 months, in fact. And so we know that when you stop the drug, there's about data that shows that about 2/3 of patients will regain 2/3 of that weight back. And in long-term surgical studies, we find that there's about a 15% weight regain in 5 to 7 year studies. And so there then becomes a balance between bridging from the medications to the drugs, to the operations. And then now we're talking about surgery plus medications as an adjunctive therapy. So we're in a very exciting time where we now have real tools in our armamentarium as bariatricians in general to say, is surgery plus medication going to be the right balance, supported by lifestyle modifications for long-term success? This is the world we're playing in today.
Jamie, thanks for going over the basics of this therapy. And many of our listeners, of course, are in the musculoskeletal world. Are there receptors in the subchondral bone, for example, or another way that these drugs could possibly be favorably impacting arthritic pain?
That I don't know about. There's nothing that I am aware of. There's anything kind of in the bone skeletal structure that cause anti-inflammatory pathway per se. But we do know that just weight reduction in general impacts the pressure on the joints, right? So if they lose 1 pound, that's 4 pounds off the pressure of their joints. Typically, that's kind of what I say to my patients as well. There's no, I'm sure there'll be research done on that. We know that there's receptors everywhere in the body, and we're just learning that how effective it is in terms of other systemic conditions as well, right?
Yeah, Mark, I explain it to patients that the adipocytes, when patients suffer from obesity, they have something called sick fat disease, and Jamie will know this, and fat mass disease. And sick fat disease is these adipocytes are releasing inflammatory cytokines. And to Jamie's point, they have a global effect on multiple parts of our body. And then there's the fat mass component, which is the mechanical component that affects Jamie's patients in terms of sleep apnea, and then our patients in gastroesophageal reflux, and then your patients in terms of joint issues and long-term success of replacements and those type of factors as well. So I think there's both the mechanical and then the inflammatory side, which affects these patients kind of globally.
Oh, thanks for that, Mo. If I could just one more, could one of you two or both run through the side effects just for our listeners who may not be familiar of these drugs?
So the most common side effects are GI side effects with the medication, right? And so that's one of the key things about management is managing the side effects of the medication. So obviously, like any medication, titrating up is the key. Going slow, doing that too as well. When we talk about the other side effects, we want to make sure that obviously, when we talk about kind of what are the risks when we take these medication, one is pancreatitis, right? And so there's a risk for pancreatitis, but in actually the studies, what they found was that even though there's pancreatitis, it was actually the incidence was the same as the general population. So there's no higher risk of pancreatitis per se, but it's something we always mention too as well. And one of the other things that then you want to think about is other contraindications for that. So if people have had thyroid cancer, specifically medullary thyroid cancer, is the absolute contraindication. And they have other multiple endocrine disorders as well, neoplasm disorders, that's a contraindication to that. The other thing that most people experience is just kind of the GI side effects of kind of eating too fast with the medication, right? Eating too much, significant gut discomfort. And a lot of times, if you educate them enough in terms of slowing their eating time down, you can actually mitigate a lot of these side effects. There is a theoretical risk of hypoglycemia in these individuals, obviously, because they do affect sugar. But I mean, these are something that we monitor, but not really of a concern. So just kind of theoretical risk.
Well, thanks for that.
Can I just ask also, and before I share with you a paper that we recently published in the Journal of Bone and Joint Surgery that's on this topic and get your take on it, is the weight loss you're getting, I say, quote, and I'll say somewhat ignorantly, good weight loss? For example, is it fat versus, I keep hearing about lean muscle mass being lost, and that's certainly not a good thing. And I'm just wondering about whether we know about the long-term
Yeah,
impacts of
very,
that?
very good question. There's definitely a concern with these medications about sarcopenia. Obviously, it's the loss of muscle mass along with weight loss in general. So actually in our clinic, what we do a medical body analysis, and we look at these compositions actually. And you're absolutely right. So there is definitely some muscle mass loss. It's very proportional, actually. And so, when you lose the weight, everything becomes proportional. And so these individuals, for example, if they have about a 40% body fat, if they lose 50 pounds, you'll still see, for the majority of individuals, a 40% body fat relative to the new weight, right? And so we're well aware of the side effects of muscle mass loss. And the holy grail of weight loss is if we can maintain your muscle mass or increase your muscle mass and lose fat. And I think some of the medications down the road is kind of trying to address this too as well. And so one of the key things is then, like what Karim was mentioning too, is a lifestyle change along with it, not just solely relying on the medication. So the level of activity they're doing, the food that they're eating, make sure, because what happens is there has to be some form of calorie deficit or energy deficit in order to lose weight. And that's what these medications help facilitate for the most part. And so if you have a slower weight loss, then you tend to have a better ratio of percentage of body fat and percentage of muscle mass too as well. So definitely does affect that. But it's really similar to even people who don't use the GLP-1s for weight loss. We still see that kind of ratio maintained throughout. But there tends to be a plateau though, right? So the more weight you lose, you'll see a plateau in terms of the amount of muscle mass loss, and you continue to have the fat loss. Obviously, you can't get rid of your muscle mass completely, so it does plateau over time. But they have to lose quite a lot of their body weight percentage in order to achieve that.
In February of this year, we published a paper that looked at sort of like a practical application. Now, it was a database study, so you take or leave what you think of database, large database, administrative database studies. But that being said, with 3 months of GLP-1 agonist use, the investigators were able to identify significant decreases at 90 days even of periprosthetic joint infection compared to people who weren't on it. Any medical complications, pulmonary embolism, readmissions. I mean, the host of things just went down. Now, these things weren't sustained up to 2 years. Is that believable to you? I mean, you're experts, you're in the area. Do you think that kind of dramatic improvement is plausible? It is an observational study, and the authors themselves did say we need to have confirmatory randomized trials. Hopefully we will get them, and I'm hoping we will. But what's your take on sort of I wouldn't say it's the frenzy, but the really popular interest in using these for, preoperatively?
I'll touch on that before Jamie, because I am not surprised that we see such a significant impact. We know that even losing, for all comers, losing 5% of your body weight shows incredible physiologic changes within a short period of time. We know for obesity-related comorbidities that patients need to lose 10 to 15% at least of their body weight in order to see an impact on their diabetes, their sleep apnea, hypertension. And then we know that from years of studies that BMI or whatever surrogate we use for visceral and subcutaneous body fat impacts how patients perform in the perioperative state and in the postoperative state. Particularly, we've been talking about sick fat and fat mass disease. We know that this would then impact their glucose profile, their risk of infections, the sustainability of that joint, their readmissions, whether it's for dehydration, pain, those type of issues. We haven't even touched on quality of life in these patients and return to work, which are incredible impacts in the orthopedic world as well. I think the sustainability is something that we're dealing with in all aspects of weight loss therapy. And, Jamie, again, will be able to corroborate that. I think in the bariatric surgery space, one of the big pulls to patients in this space is that there's increased sustainability in long term, and the medications are able to achieve that weight loss. But again, stopping those medications leads to weight regain. And that's why I think the future is going to be using these therapies together and having long-term impacts for patients and supporting them after orthopedic surgery to say maintenance of that weight loss in the post-operative state will achieve long-term impacts on these orthopedic metrics.
One of the things we look at is inflammation in general, and Karim pointed to this, how the biggest organ in terms of cytokine and in terms of endocrine system is probably the fat system. There is a ton of cytokines that get released, tumor necrosis factor, all these kind of cytokines that lead to inflammation and poor health. And so when you start to lose this weight, you improve the epinephrine, which is the good cytokines for and hormones for health in terms of the fat. And so we see this kind of reversal. I mean, you also have to look at what the risks with obesity is. Increase, VTE events, increase infections, cardiovascular events. And if you just turn it upside down, you have the weight loss, you have the reduction. So it's very believable, I think. That study points to something we should research upon, is that in the first 3 months, we can see this dramatic improvement, because in the first 3 months, some of these individuals can lose about 5 to 10% of the body weight. And so one of the things I always quote in my sleep practice is that patients who have significant sleep apnea, if they do a lifestyle change and lose 10% of the body weight, they can reduce the sleep apnea up to 50%. And that's phenomenal, right? In terms, you can bring someone from severe to almost to a mild degree of that. And just a simple fact that, sleep apnea is also inflammatory, a low-grade inflammation people don't talk about. And so, all these other improvements we do probably will leads to inflammation that probably leads to a lot of the improvement in terms of the overall health. Now, as Karim alluded to, weight regain is a big issue. And so if obviously, from a longitudinal perspective, the tendency is that you got to regain your weight, even if you stay on the same medication dosing on the GLP-1s over 5 years, 6 years, you'll start to tend to gain a little more weight too as well. Obviously, we know that in the STEP trials, the 5-year trials, they do regain some weight, but still substantially less than the individuals who come off the medication overall. So I think there is a recurrence of some of the inflammation that goes on. That's why we might see the effects waning over time.
The one thing, Mo, I'll mention on this before I think it's particularly important in the orthopedic population is that we have to also be conscious in the post-operative state for orthopedic patients on their nutritional profile, because it's not as common in the drug population, but in the surgical population, nutritional markers where they have vitamin deficiencies, whether it's, iron deficiency is common, the vitamin K, A, D, E, and, calcium is an important factor in long-term success for orthopedic patients. So we often pat ourselves on the back for short-term successes, but it's long-term that really has an impact on these patients. So I think what we're getting at is that there's pillars of therapy that really need to come together more than ever before in order for us to realize those long-term gains for these patients.
I mean, with the dramatic increase in use, and also the fact that that there are new drug formulations coming out, and I think, Jamie, you said something right at the beginning, and maybe I'll end with this. A bit cheeky comment for you, Karim, but I'm generally curious if this is happening. Karim, Jamie, you had mentioned that, the medications are getting to bariatric levels of weight loss. If I'm a medical student thinking about general surgery, am I going to be rethinking bariatric surgery as a subspecialty for myself in 5 years? Am I going to be seeing a decrease in that fellowship opportunity, or are you arguing, in fact, that no, there'll always be a need for the surgical interventions?
Personally, I'll go first, Karim, if it's okay, because I know I'll leave the final words to you. But working with Karim, working with their team, there are side effects to the medication, and the failure rate of GLP-1s in Ozempic is fairly high. I want to say it's for 15 to 20%, first of all. And so you can see there's already a cohort that does not respond to GLP-1s or do not respond favorably, compared to the studies, right? And there are individuals in my practice just don't want medication. They want that kind of surgical intervention and that commitment to changing their life, right? It takes a lot more commitment from a psychological perspective too as well. So I deal a lot with, patients who've had surgery 7 years ago and have regained some weight and they're looking, I definitely do think there is a role for surgery. I do think it makes both worlds a lot better in terms of the medical and the surgical world. Karim can talk to this in terms of, I think that's definitely a misconception of how dangerous bariatric surgery is. And I think, Karim, you might want to talk about this, is that it's very safe, and so we should not discredit that because we have effective medication that can reach, probably, I would say, next few years, reach bariatric level, that we should not consider bariatric surgery as an option.
Yeah, I mean, I would totally agree. I mean, it's an exciting world where the internist backs up the surgeon and the surgeon backs up the internist. And the idea is that in bariatrics, medicine and surgery has been siloed for so many years. And because now we have a real, tool with bariatric medications, when we were just using, lifestyle modifications and, very low energy diets to treat patients before, we're now realizing that these two worlds are coming together in a real way. And that in weight regain patients, my first offer to them is that you should try the GLP medications before we consider surgery. And surgery, just like Jamie's saying, the risk profile has changed by orders of magnitude in the last 15 to 20 years, where the risk of major complications is less than 1%. At St. Joe's Hospital in Hamilton, we have the largest same-day discharge program in Canada for bypass patients. When those patients 15 years ago, 20 years ago, were all going to the ICU after surgery, whether or not they had complications or not. So there's been such significant changes. Is the future of surgery going to change in bariatric surgery? Yes, of course, I think so. And it's on us to adapt as we provide the best benefit for the patients for the lowest risk profile. Will there always be patients that will need a surgical option? Yes. Will there always be patients that need surgery plus medications? Yes. And then will there be patients that will always need just medications alone? So I think it's our role as clinicians to be adaptable, to see how that world changes. And I think we know with AI and robotics, the world of the surgeon is going to change in the future. It's just how we become players in that game. And so I encourage, students to, pursue what excites them today, because that might not be the way they practice in 10 years, but it'll be equally exciting.
Oh, great. Thank you very much. And like I said, I mean, everything you've talked about has almost direct implications to the practice of orthopedic surgery and managing orthopedic patients. So thank you both for taking time. Marc, as always, thank you for sharing another great cup of joe and a good morning to start off our midweek. So thank you both, and appreciate your time with us.
Pleasure. Thank you.
Take care. Thanks for having us.